Thank you for joining us for the 5th Annual Global Summit on Kidney Innovations, If Not Us, Who, and If Not Now, When, a collaborative partnership event presented by the American Association of Kidney Patients and George Washington University School of Medicine and Health Sciences. My name is Melissa Bensouda, and I am an AAKP Ambassador and home hemodialysis patient. I was 24 years old when doctors diagnosed me with chronic kidney disease. I had just given birth to my second child, and after the birth of my third child, I lost all functionality of my kidneys. I was blessed to receive a donor kidney in April of 2012, and that kidney lasted about 5 years. I have since returned to nocturnal home hemodialysis. Despite me being a full-time working mom who adores my now 3 adult children, I have a passion and am committed to bringing awareness to kidney disease and doing what I can do to support fellow kidney patients through their journey with this disease. Being a part of AAKP since 2016 has allowed me access to the education and resources that I needed to improve my quality of life as a patient, and also a platform to use my voice and my experiences in a very meaningful way, to demand more innovation and more choices for myself, and not just for me, but for other patients diagnosed with kidney disease and those who have yet to be diagnosed. In 2019, AAKP announced 2 major initiatives, AAKP Global and the Decade of the Kidney. AAKP is engaged internationally because we are committed to educating patients and leaders across the globe on the importance of kidney disease prevention, new awareness in treatment, new innovations, and the necessity to save more lives. We believe that a united patient voice can drive more intelligent alignment of the policy, regulatory, and payment decisions necessary to bring new, safe innovations to patients without unnecessary waiting and needless interference. Across the globe, AAKP is working with patients, medical professionals, researchers, and the medical industry allies to address the many unmet needs of the global kidney community. AAKP believes this international collaboration can help close the gaps in the U.S. and in countries where healthcare systems and/or infrastructure do not fully support patient consumer choice or immediate access to new treatments. It is my distinct honor to moderate our session titled Innovations in Emerging Opportunities, Common Complications of Kidney Disease. And today you will hear from 3 esteemed speakers whose work is making great strides in the kidney space, helping patients manage many of the coexisting conditions that often come with kidney disease diagnosis. Each of the speakers is a strong patient advocate with tremendous empathy and concern for patients and their families. We're going to begin first with Dr. Ajay Singh, Senior Associate Dean for Postgraduate Medical Education and the Director of the Masters in Medical Sciences of the Clinical Investigation Program at Harvard Medical School. Dr. Singh is also a senior nephrologist at the Brigham and Women's Hospital in Boston, Massachusetts. His interests are in clinical research with a particular focus on the anemia of chronic kidney disease. He led groundbreaking studies in anemia of kidney disease, including the Choir study, which was published in the New England Journal of Medicine, as well as being a member of the steering committees for the Treat and Drive studies. More recently, he has taken on the role of leading the Ascend clinical development program. 4 of these trials have been published in the past year in the New England Journal of Medicine, JAMA Internal Medicine, and CJASN. It is my honor to welcome Dr. Singh to the podium.
Thank you, Melissa, and thank you to the organizers of AAKP and the Global Summit, and to my good friend, Professor Raj as well, who helped invite me here. You folks do God's work. Patients, I think, really have a tall task to manage chronic kidney disease, particularly when they're on dialysis, or have had a transplant. And I think having such an important society making such important contributions is really, really key. What I'm going to do is firstly just cover for you some introductory things that you probably have already heard, and then give you a little story about some of the innovation that's occurring in the field of kidney disease, at least my version of it. I think everybody knows the impact of kidney disease is just staggering. There are, I think, 1 in 7 Americans have kidney disease. It's higher in certain ethnic groups like Latinos, Native Indians, and African Americans. Globally, chronic kidney disease affects about 850 million people. And even within the United States, where we consider ourselves a rich country, there are an extraordinary number of disparities of care that occur, so that people who are who live in rural versus urban communities don't get the same sort of access. Individuals who are minorities don't get the same sort of access as others. So I think we would all agree that the status quo with respect to chronic kidney disease is really unacceptable. On this slide, you can see some of the trials and tribulations that patients go through. And all of us who either practice nephrology, see patients on dialysis, or are patients who have kidney disease or actually experience dialysis know that the situation currently is not acceptable. And I think we also should all agree that a coordinated national effort will speed innovation and change lives. Indeed, I've written a few editorials that have sort of tried to tease the federal government to think not only about a cancer moonshot, but to think about a kidney moonshot. Wouldn't it be great if we had large investments in, for example, dialysis care, where shouldn't always be about profit, but it should be about innovation and progress in developing new strategies of care. And so millions of people are waiting for breakthroughs in kidney health. And this slide that I share with you is from Kidney X, and it really is remarkable that over the past 20 years, so little progress has been, at least in dialysis. But there has been some progress. And if we go to this next slide, you can see my list of areas where there has been innovation. And this is not an exhaustive list. I have 2 colleagues in the panel who probably quibble with me and say, well, they also have drugs or agents that could get on the list. And I didn't take an exhaustive list. I just took some examples. I think we all agree, and I'll share with you some more details on this, that there's been tremendous progress in slowing progression of kidney disease and type 2 diabetes. The number of new agents that have been developed over the past 10 years has been really mind-boggling. And recall that type 2 diabetes is responsible for around 40% of all people with chronic kidney disease and has tremendous comorbidity. More people die with chronic kidney disease from type 2 diabetes that end up on dialysis. It results in one of the commonest causes of hospitalizations among patients with kidney disease, heart failure hospitalizations. So the idea that we might actually have progress in developing new drugs with type 2 diabetes is really important. And a related condition, if you will, of obesity has a whole slew of new drugs that have come on the market that will probably make surgical interventions for obesity a thing of the past. I've spent a fair amount of time over the past 25 years thinking about chronic kidney disease anemia, and as I'll share with you, there's a new class of agent that could have the potential to replace intravenous or subcutaneous erythropoietin with an oral agent for the treatment of anemia that also potentially has benefits in influencing iron metabolism and might reduce the need for iron repletion. We have a new therapy just approved for IgA nephropathy. We have exciting work that's published in the New England Journal in the last 9 months on APOL1-mediated diseases. These are this mutation in this gene is associated with a higher risk of kidney disease among African Americans in particular. There's been progress with newer agents coming down the pipeline, not in addition to tolvaptan for the treatment of autosomal dominant polycystic kidney disease. There's new agent for the treatment of lupus nephritis that's been approved by the FDA. New agent for pruritus, which is an extremely challenging thing to deal with for those who have itchiness on dialysis. Well, there's a new agent that's now available and approved. And there are newer kidney transplant rejection approaches also there. We have, in addition to these new drugs, we have new approaches, because innovation is not just about discovering a new drug. Innovation is also thinking about new approaches to things, right? And so we have a new equation to estimate kidney function that doesn't include race, that could have meaningful impact on the ability of African Americans to meet criteria for kidney transplantation. There's a new approaches to developing ways of avoiding blood thinners in dialysis patients. A lot of patients who are on dialysis often end up requiring blood thinners because their dialysis membrane clots. And the ability to avoid that by newer membranes might mean that patients who are on dialysis don't sometimes get the bleeding and the bruising that is so commonplace among dialysis patients. There's a new anticoagulant that might be available so that we might be, for dialysis patients, that might avoid the need for warfarin or for other types of treatments that patients currently need. And there are new care delivery models and reimbursement strategies. So I think the future is not dim, the future is bright, but we've waited an awfully long time for even this future. This next slide shows you something that I've spent the last few years thinking about, and that's what's happening with type 2 diabetes and kidney disease. On this slide, what you see are the pharmacological innovations over the arc of about 40 years. When I started my training at Tufts Medical Center in 1987, we just saw the emergence of blockers of the renin-angiotensin system, ACE inhibitors and ARBs. Everyone needed to be on these agents, but it took a while. It's taken 30 years, and now, on average, about 40 to 60% of patients with chronic kidney disease are being treated with these agents. There's still gaps in care. But these agents, RAS blockers, as they call them, renin-angiotensin blockers, only really mitigate the risk of progression of kidney disease by about 40%. So there's 60% residual risk that was still on the table from the 1980s to the last 10 years or so. And then in the last 10 years, we've seen the emergence of SGLT2 inhibitors. If you imagine that the kidney reclaims all the glucose that is filtered, so about 170 grams of glucose that's filtered, by blocking the channel that reclaims that glucose from the urine, you actually open the faucet, and patients with diabetes can leak glucose. So the more, if they eat sugar, the sugar comes out in the urine. But these agents, which have osmotic/diuretic effect, also reduce the risk of progression of kidney disease. They good agents for managing blood pressure, and they reduce heart failure and other cardiovascular events in patients with chronic kidney disease with diabetes. And so SGLT2 inhibitors have emerged over the past 10 years. But where's, wonderful to see these agents, but recent studies suggest that only around 15% of patients who should be on treatment with SGLT2 inhibitors are actually receiving SGLT2 inhibitors. Use of these agents with RAS inhibitors lengthens the time off dialysis with patients with chronic kidney disease by between 10 to 15 years. And yet, only a fraction of patients are actually being treated. Another agent called non-steroidal mineralocorticoid receptor antagonist, finerenone, was approved about 2 years ago by the US FDA, and that layered on top of SGLT2 and RAS inhibitors potentially has the promise of slowing progression down even further. So from an average of about 10 cc's per year of kidney progression down to around 3 or 4. So now we're getting 60% reduction in risk of kidney progression. And then, of course, the latest kid on the block is our GLP-1 RAs and GIPs. And these drugs are very effective in reducing obesity, about a 30% reduction in weight within about 2 months, but also are very effective in treating diabetes and have the potential to slow progression even further. So here's an innovation that evidence supports, namely slowing the progression of kidney disease down so that we have the potential that virtually nobody will end up progressing to kidney failure if these drugs work layered one on top of each other and slow progression. But the challenge is that only a fraction, only 15% of patients are just taking an angiotensin receptor blocker and an ACE inhibitor and an SGLT2 inhibitor. So heaven knows whether there'll be what the uptake will be of adding on their finerenone and a GLP-1 RA or GIP agent. And so here, the innovation we need are new forms of education, patient awareness. So patients are pushing their doctors to say, I want everything. I want you to throw the kitchen sink at my type 2 diabetes and prevent progression of kidney disease, because nothing else is acceptable. And I'm not just saying this. This is now supported by the American Diabetes Association guidelines and the kidney global guidelines from 2022, late 2022. So nothing I'm saying is really a surprise. And you can see in this pyramid, all of these 4 agents have been cited as being of value in preventing progression of chronic kidney disease in patients with type 2 diabetes. So imagine the possibility that 40% of our patients with kidney disease, whether the kidney disease not requiring dialysis or requiring dialysis, could have that prevented with new agents. But of course, not only do we need the new agents, we need new agents that are actually being taken by patients. And so we need innovative strategies to educate patients. We need patients to push providers to treat them with these agents. They're all approved by the FDA, and to really benefit from them. The question that you'll often ask, well, what are these innovative strategies other than patients demanding them? Well, it turns out that treatment of diabetes is a team sport, right? It isn't done by one person. Early on, it's the primary care doctor. When patients have more advanced stages in 5 to 10 years, they start requiring a multidisciplinary team of the primary care doctor, the diabetes team, often involving a diabetes educator and a nephrologist. And then later, we'll add in or layer in a cardiologist. So innovations not only involve patients being educated and being more demanding of these sort of therapies, but it's also making sure that people are able to work together as a team. They understand the nature of these drugs and are able to offer them to patients. Some people say, well, of course we'd like to treat these patients, but the co-pays are so expensive and it's difficult to work through the gamut of all the bureaucracy required to get approval or pre-authorization. Of course, but that's, ask a patient who's on dialysis because their diabetes progressed. I think they'll say, I expect that of my caregiver, to fight those battles so I can get all the agents that are required. And in this regard, nothing is not at all different than the situation with cancer drugs. Patients deserve cancer drugs because it allows them to survive longer. Patients need drugs that prevent progression of kidney disease and diabetes because it allows them to survive longer. And then this slide is the 35-year view of CKD anemia in patients with kidney disease. By the time patients progress to end-stage renal disease on dialysis, virtually everybody is requiring some form of erythropoietin, whether it's EPO injections, subcutaneously or intravenously. Patients require that. They require iron therapy. And as you know, prior to 1989, the only treatment that was available were blood transfusions or no treatment at all. I remember when I started training as a renal fellow in Boston, we would have patients coming in who had evidence of iron overload, or they'd come in pale because their hemoglobin was 6 or 7, hardly functional. And then, of course, Epoetin came along. Research in the next 10 years, of which I contributed to 2 of the 3 major trials, showed that all wasn't great, that treating patients aggressively with erythropoietin to get their hemoglobins up rapidly wasn't necessarily the right approach, that there were perverse incentives that were in place so that physicians, providers, and dialysis companies were making money off the backs of patients and using very high doses and raising hemoglobins very rapidly. And all of that came down to a sensible level when the FDA restricted the hemoglobin target. But restricting the hemoglobin target had its own risks, increasing the risk potentially of blood transfusions and of making patients potentially more symptomatic. And so in '89, the machinery by which patients detect low oxygen levels was discovered. And in the next 10 years, in early 2000, compounds were developed that can be used to stimulate production of endogenous erythropoietin produced by the body itself, by not only the kidney, if the kidney has function, but also by the liver. And so what ended up happening was new agents were developed, and 3 new agents have gone through phase 3 trials, roxadustat, daprodustat, and vadadustat. And these 3 agents, they're called HIF-PHI inhibitors because they trick the oxygen sensing machinery in the body to think that the body conditions are hypoxia, and you get stimulation of endogenous erythropoietin. You don't need to give exogenous EPO. So imagine now a world where you don't need injections. If you're a home therapy patient or a PD patient or a dialysis patient who's on subcutaneous erythropoietin, you can use a pill. You don't have to go in from your place at home in some rural community to an EPO clinic. You can take a pill. Roxadustat went through the whole approval process. Unfortunately, was not approved in the US, but is fully approved in Europe. Daprodustat, the program that I led, the ASCEND trial program, was approved for dialysis patients in the United States and will be launched most likely in September of this year and will be available for patients who are on dialysis, particularly beneficial to home therapy patients. Daprodustat was also approved in Europe, or will be approved, had a very favorable review for dialysis patients. And then vadadustat is not approved in the US, but is approved in Europe. So there is promise of these new oral agents, and we'll have, further studies will need to determine how they impact on iron metabolism as well. This is a paper that was published, it has Paul Conway actually as the senior author, a senior leader in this, in AAKP. And I would encourage you to read it. It's published last year in C. Jason. And it talks about breaking the barriers to innovation in kidney care. And some of the highlights in this 7-point recommendations that they had, that these authors had, was, I think, worth highlighting. One was engage. We need patients and the general public to engage. Innovations will not only not happen, but may not be fully played out in terms of use of innovative therapies unless patients and the public engage. It's important to go through all the other things. I can't see the slides here, but I'll see them on the back here. You want you want people to articulate the narrative of the clinical journey, and some of the speakers, particularly in the previous session, certainly did that. You want to identify executable innovations. You want to educate key health science investors. There's no innovation that easily happens in the US or anywhere in the world without getting the investor community to think that there's potential there. You want to collaborate with key advocacy organizations. And of course, on this list, AAKP is there, and AAKP, of course, collaborates with our key nephrology organizations. You want to leverage the involvement of key federal agencies like the VA and the Department of Defense. And you need to understand that new care models will also be required to fund some of these therapies. So I just want to say again, thank you very much for your time, and I'm going to yield to the chair. Thank you.
Thank you, Dr. Singh, for an excellent presentation. Our next speaker has been a longtime friend and a distinguished former board member of AAKP. Dr. Tejas Desai is the director and head of the U.S. Difelikefalin program and medical and scientific affairs for CSL Vifor. He began his career in academia as a training program co-director for the internal medicine residency program and then nephrology fellowship director at East Carolina University Brody School of Medicine. Following his career in academia, he joined the Department of Veterans Affairs and was privileged to serve as our veteran CKD and ESRD populations. Now at CSL Vifor, he continues contributing positively toward the health of kidney patients. Please welcome Dr. Desai to the podium.
Good afternoon, everyone. Thank you for having me. It's really a privilege to be here. I love talking to people who are committed to patients as much as I am. So it's nice to be around you guys and to share ideas. And it's nice to share what we're going to talk about today. So we're going to talk about innovation. And I said to myself, you know, everyone in this room knows that innovative ideas and products and devices and workflows all benefit our kidney patients. That's an established fact. We don't have to prove that anymore. So what I thought about was, what does innovation itself need in order to grow and thrive in our world with kidney patients? What are the starting blocks, the primordial components of innovation that need to be present in order for innovation to materialize and then do its thing, which is deliver value to our kidney patients? And then I started wondering, once innovation does deliver value to our kidney patients, is that all that it does? Or is there something else that our patients and we as providers can extract from innovation to keep it going? And so that's what I'd like to talk about today. So let me orient myself. There we go. So I'll tell you a series of nonfiction stories. And I hope that in these stories you'll get an idea of what are the primordial components of innovation, things that I think are needed for innovation to occur and to grow, and then what else we can do with innovation besides just extracting value for kidney patients. Is there something else of value that we can get? So let's start first with who I work for. I work for CSL Vifor. That might not be a company with which you're familiar because it's a merger of two companies, CSL and Vifor Pharma. You've probably heard of Vifor Pharma. CSL is a company based in Australia. So we've been around coming on about a year, maybe a year and a few months. And when these mergers happen in our industry, there's often a focus on the assets and the resources and the synergies that come by putting those things together. And that's important for certain stakeholders to know, but what's important for patients and for innovation is what else is being combined, what other synergies are happening. So what you see on the screen are 5 rectangles, and a cursory look at those rectangles might make you think, well, those are the therapeutic areas and therefore the assets and the resources that this company brings to the kidney patient. What I'll say is look deeper. These aren't just assets and resources. There's something more important behind these boxes. These are commitments. These are the commitments that our company and the people who work in it make towards kidney patients. And so when you synergize two companies, you're not just looking at the present portfolio of commitments that we've made to kidney patients. You also want to look at the pipeline of commitments. And so there is number one, what I consider one of the first ingredients, primordial components of innovation, which is to have a commitment to the population you wish to serve. So this slide starts off by saying patients with kidney disease face a long and difficult journey. I could show you numbers and I can show you data, but I probably will not do that from this point forward in my career because to me, this is an established fact. This does not need to be proven anymore. So what needs to happen now that we know that this is an established fact is that we have to bring all hands together. We heard from Yessi earlier in the morning before lunch what happens when all hands come together. When staff and patients come together, they can take a hurricane-ravaged dialysis clinic and turn it around into an operational facility in 2 hours on an island. And so collaboration is number 2 as one of the key first ingredients in order to have innovation. Not just any form of collaboration, not just all hands, but coordinated all hands. So coordinated collaboration, intentional, purposeful activities that each stakeholder performs in order to move the goal forward and move the ball forward and get closer to the goal. So number 2, coordinated collaboration. If you're going to treat patients and help kidney patients, I have found as a physician, it helps for me to be patient. And you may have found that yourself as well. The journey with kidney disease is long and arduous, and the journey to find solutions for all of these kidney conditions is also long. We need to be patient and we need to be persistent or dogged, or as my wife says, just flat out stubborn. And so that comes to number 3, the character of the scientists and the individuals who care about kidney patients. It's a first ingredient for having innovation in our field. There in the middle, you'll see number 4, believing in the unmet need. So our beliefs in what kidney patients need come from the patients themselves and how we interpret scientific data. And when we start our journey to finding solutions, we're excited, we're enthusiastic, we're motivated. And too often, time and challenges can erode that enthusiasm and excitement. So we need something that is erosion-proof, something that will not decay as time goes by. And I call that ingredient number 4, conviction. So we need character and conviction in order to help innovation happen. All right. I am now going to tell you another story, nonfiction. And if I do justice to this story, then you will see at least one of the 4 primordial ingredients for innovation in the story. So let's see if I do a good job. Our story starts before the smartphone was invented, in 2004, when a group of scientists from 3 different organizations decided to study a product called CR655. I don't know where these names came from, but they decided to study this molecule because they thought it had promise in treating pain that patients experience. They didn't know what type of pain, they didn't know exactly which patients, it was too early to know these things, but they thought there was a promise that this molecule could do something of value for patients who suffer from pain in general. So they started working on this molecule and ran into obstacles like we would all expect that they would. And they decided how to proceed, and finally the decision was made to start to re-engineer this molecule because they started noticing that the data was suggesting that maybe pain isn't the area where this molecule has the most promise. And perhaps some re-engineering would allow it to be more promiseful in another area. So in 2007, this molecule is re-engineered into something called CR845. I still have no idea where these names and numbers come from. And CR845 then undergoes testing. Now, this slide is misleading, okay? It's intentionally misleading. I did it this way on purpose. You'll skip the first chiron, which says 2007. You will see all the other years, and they're pretty close together, right? 2 or 3 years apart. The big gap is between 2007, the first chiron, and 2014, the second one. What happens in this 8-year time period? So the molecule is re-engineered, it's refined, it's tested, data collected and analyzed, and undergoes more refinement, more re-engineering. That's not the only thing that's being re-engineered in this 8-year period. The perspective of the scientists and the stakeholders in these companies is also changing. It's also being re-engineered as they learn more month by month about what this molecule can and cannot do, to the point that they see that the promise of CR845 is not in pain, but in another condition that starts with a P, pruritus. And so now their perspective has changed. They see promise for this medication in another area that heretofore was not on their radar screen, pruritus, and they decide to do proof of concept studies. There's a lot of P's in this story, okay, I admit. So proof of concept, proof to whom? We often say proof of concept is for investors and shareholders, and that's true. They need proof of concept studies to be done in order to move forward with what they're going to do. But sometimes scientists themselves need to have proof of concept studies to prove to themselves that the evolution that they've experienced, in this case in 8 years, was sending them in the right direction, that it was getting them closer to helping patients. And so in these 8 years, all these tests are done, things are re-engineered, perspectives are changed, and promise is now materializing. They see that there's promise for this medicine for this condition. And then you can see things move at a pretty steady clip, which is what we would expect in the development of a drug. All right, so I've talked to you about the story. I hope you have seen some of the first ingredients in this story that are required for innovation to exist and to flourish. What happens once innovation comes? Is the only thing that we can extract from it value to the patient? That is a big thing. That one would say is probably the 99% most valuable thing innovation can give us. But what else can we get from innovation? We can get this. We can get an entirely new way of thinking about the problems that affect patients. Let's look at the first thing on the left-hand side, peripheral KOR agonist. The key word in that phrase is the last one, agonist. Nephrology is a specialty that uses blockers, inhibitors, antagonists. We are heavy on the defensive side of the spectrum. There's nothing wrong with being heavy on the defensive side. I'm a fan of the Giants. I'm a Bill Parcells fan. Defense wins Super Bowls. There's nothing wrong with playing defense. But from time to time, we want something on the offensive side of the field because that can help patients too. That type of innovation, however, requires an entirely different mindset by the patient and by the physician that treats him or her. Agonists, doing something in the body to promote something else, which promotes something else, which will ultimately lead to some sort of a benefit. It takes time to understand, time to become familiar with, and it's one of the things we get when we have innovation. The second thing, not on this slide, but it was on a previous slide, I'm not sure if you caught it, was the idea of symptom-based care. And so we are all focused on prolonging the lives of our patients. We are all focused on prolonging our own lives too, let's be honest, right? And one of my favorite patients, and I had the privilege of caring for veterans who have lots of very wonderful, interesting things to say. One had said to me, we all want to go to heaven, but none of us want to die to get there. So we focus on mortality a lot, and sometimes we forget that the life that we have right now is also important, and it needs to be cultivated and cultured and given some TLC so that we can live the best life possible. That's the mantra, or at least the fundamental principle behind symptom-based management, which an innovation can bring to the fore in the minds of the patient and the minds of the physician. So I'm going to wrap up here. I have to show you some obligatory slides because I did mention a medication, so there is the side effects. But I'm happy to take any questions at the end, and I hope I've been able to give you a little bit of a construct of how we see innovation. It's not just the innovation itself, it's the ingredients that go into it, and it's all the extra that we can get out of it so we're prepared for the next round of innovation when we have the privilege of undertaking it. Thanks very much, everyone.
Thank you, Dr. Desai, for such an informative presentation. Our next speaker, Dr. David Spiegel, is a national and international figure in the area of nephrology. Prior to joining Ardelyx as Vice President of Nephrology, Dr. Spiegel served as the global lead for clinical development for the nephrology therapeutic area of Vifor, and Executive Medical Director of Nephrology at Ardelyx. Prior to joining the pharmaceutical industry, he was a professor of medicine at the University of Colorado Health Sciences Center and served as a medical director of the ESRD and CKD programs. During his academic time, he contributed to important research advancing the field of calcium and phosphate metabolism in CKD and its role in vascular calcification and cardiovascular disease. Please welcome Dr. Spiegel to the podium.
Thank you, Melissa and the AAKP. It's a pleasure for me to be here. It's a pleasure for Ardelyx to work with you to improve the care of patients with chronic kidney disease. And I see that my time is almost up, but I will proceed anyhow. So I was asked to speak about the XPHOZAH journey. And since I had all of 15 minutes, what I thought I'd speak about is actually 3 journeys. So what I want to tell you about is the scientific journey, the regulatory journey, and then what I'm calling the access to care journey. And I'll start with the scientific journey because despite what you may have heard, science is still very important and actually very fun and very exciting. So XPHOZAH, for those of you who don't know, is the proposed brand name for a drug that's not yet FDA approved, but is under review by the FDA for the treatment of hyperphosphatemia in patients with chronic kidney disease on dialysis. And the generic name is tenapanor. And what tenapanor is, it's an inhibitor of the sodium hydrogen exchanger 3, and it works within the GI tract. It's minimally absorbed, so it works within the GI tract on this antiporter, and it blocks some sodium absorption, and it inhibits some hydrogen ion secretion to a small degree. So when you have more sodium in the GI tract, that holds on to water, and it softens the stool, and you're thinking, okay, tenapanor, we're talking about phosphate today, but when you think of holding on to stool water, you would think maybe that should be used for a problem with constipation. And indeed, tenapanor is approved under a different name called Isbrella for a treatment of a disorder with severe constipation, which is irritable bowel syndrome with constipation. So how do we get from a drug that inhibits a sodium hydrogen antiporter to lowering serum phosphate? And this was a study that I'll show you a little bit of data here that was done early in the development pathway of tenapanor. And what they did is they decided to look at the effects of tenapanor on sodium and fluid balance in patients with chronic kidney disease. Now, some of these patients had hyperphosphatemia and some were on phosphate binders. And when they looked at this data, right, you do the primary data for your study, but in any kind of study, you also gather additional data. A lot of it is just to look at safety and other aspects of the drug. So when they looked at the data on phosphate in this study, mainly for safety, they saw when patients were on tenapanor, their phosphate went down, and when they came off tenapanor, it went back up. Well, depending on who the scientist was working on this study, they very could have easily looked at this and said, I don't see a safety signal. The phosphorus doesn't go below the normal range, and they could have dismissed it. But it turned out the investigator who was working on this trial had previously worked at a company that developed one of the phosphate binders. And he was very aware of the importance of phosphate in patients with chronic kidney disease, the deleterious effect of elevated phosphate in those patients, and the difficulty patients have of lowering their serum phosphate. And he wondered, this was a relatively small study, if this was a real effect or was this just an anomaly of the data in small numbers. So what he did was he went and looked back at other studies of tenapanor in patients, and these were basically healthy people on fixed diets, so they were on a fixed sodium and fixed phosphate intake, and their stool and urine had been measured. And so they went back and looked at the amount of phosphorus and urine in the stool and the amount of phosphorus in the stool and the urine of those patients. And what they saw, you see the change from the gray bars to the blue bars, and then when patients were on tenapanor, their stool phosphorus went up and their urinary phosphorus went down. And that was consistent across all the trials they could look at that evaluated this effect of tenapanor. So it was very clear early on when they looked at this data that tenapanor was doing something to phosphate. It was blocking phosphate absorption. So how could it be blocking phosphate absorption? It's not a phosphate binder, right? It only works on this NHE3 antiporter. And so to understand this, we need to go back 40 years, right now back to 1983. And these were elegant physiologic studies done by Dr. Fortran's lab in Texas. And that was Texas at the time when it was not too hot to live there, actually. And what they found, that was a poor climate change joke, and what they found is that phosphate absorption follows this red line. So at low levels of phosphorus in the GI tract, there's this curvilinear nature, and then it becomes a straight line. And he was able to dissect out that there are actually two components to this line. One is, I can't see the color, I think it's the black line you see at the bottom, that's curvilinear and levels off very quickly, and another is a green or a blue line that goes up linearly. And it turns out that these two components of phosphate absorption correlate very nicely to how phosphate is absorbed in the GI tract. This curvilinear thing that goes up a little bit and is very effective when phosphate is low and then levels off actually correlates very nicely to what we call transcellular phosphate movement. Very specific receptors that bind phosphate, bring it into the cell, and then it's excreted out the other side, right? That's limited by the number of those transporters, and also it's very energy dependent. The other way phosphate moves from the GI lumen into the body is this paracellular pathway, this pathway between cells. And there are channels that are formed by the structural proteins that link cells together. But this pathway is not energy dependent, and it's basically driven by the concentration gradient, the electrochemical gradient for phosphate from within the GI tract to sort of within the blood space. And these correlate to the transcellular and the paracellular pathway. So how does tenapanor then still prevent some phosphate absorption? And that's shown schematically in these figures. So the left-hand figure, we see this NHE3 receptor, and we see this gap between the cells as being relatively wide open to phosphate and phosphate moving between the cells. And then on the right, we see what happens to those cells when tenapanor binds to this NHE3 receptor. So it prevents some hydrogen ion from being secreted, and we think, and we don't know necessarily the second or the third messenger, but somehow that prevention of the hydrogen ion secretion changes the conformational structure of those tight junction proteins between cells, and increases the resistance or decreases the permeability of that paracellular channel to phosphate. And so it blocks some of the phosphate movement through this paracellular channel. And this was work that was done by the scientists at Ardelyx to work this out. So once you have your molecule and now you understand how it works, obviously it's important to do the clinical trials to show that it's clinically effective and safe. And I'm not going to go through these studies for the sake of time, but the light blue bar is the phase 2 trials, the darker blue bar represents the phase 3 trials. All the phase 3 trials met their primary and key secondary endpoints. We had efficacy, we had tolerability and safety data in over 1,000 patients. And then we were ready to launch into the regulatory journey. And now we were pretty comfortable about this because we knew, right, that elevated phosphorus does bad things for patients with kidney disease. It does bad things to the bone. It does bad things to the cardiovascular system, right? We knew it was a large burden for patients. Patients have to take phosphate binders, which is the only treatment available for this disorder. And they tend to have to take a large amount of binders, right? The figures on the right slide, the right side of this slide shows maybe a daily dose and then a weekly dose of maybe the more common phosphate binders. And all of them have some tolerability issues. They have GI side effects, and generally patients have trouble taking this number of pills every day of their dialysis life to keep their phosphorus controlled. And if you look at a dialysis unit in any given month, about 40% of patients are out of control. And if you look over a 6-month period of time, right, only about 20% of patients are able to stay in control over a 6-month period, meaning 80% of patients move in and out of our target range. So that we felt there was clearly a large unmet need. So we took our data package to the FDA, and this is where I guess perspective is important, right? We knew we met our key primary and secondary endpoints. We knew the large unmet need. We knew the tolerability and safety profile of the drug. And I think the regulatory agency kind of said, well, we're a little concerned about the clinical meaningfulness of your effect size, and there are other therapies that may be available. And that's despite the fact that we kind of went back and said, but in the left hand, you see the daily dose of tenapanor. It's 1 pill twice a day, the pills being a little larger than a Tic Tac, and on the right being sort of a daily dose of a common phosphate binder, right? And so we thought that there was innovation here, there was a novel mechanism of action, and we thought that our drug should be approved. So to shorten this regulatory journal, I've just listed the dates here. We filed in 2020, and about a year later, we got what's called a CRL, which means our drug is not approvable at that point. We then filed a formal dispute resolution, initially with Ocean, and then it was bumped up to the Office of New Drugs, and they granted us an advisory committee meeting. And what an advisory committee meeting is, it's a panel of experts that the FDA selects, and in this case, it was cardiologists and nephrologists and some statisticians, many of them who have clinical experience in taking care of dialysis patients. And so that meeting took place in November of 2022, where we presented our data to this panel, and we got a very favorable vote from the panel for tenapanor. And so in December of 2022, our appeal was granted, and in April of this year, we refiled our new drug application, and now we have a new PDUFA date in October of this year, and prior to that date, we hope to work with the FDA for the label. So now let me turn to what I'm calling the access of care journey to sort of end this out. Obviously, you can have great science, right? You can have a drug that's approved, which we're not there yet, but we're hoping to get there pretty soon. But obviously, if you can't get that drug to patients, right, if the patients can't have access to that drug, then you really haven't achieved the goal, and you haven't achieved, obviously, the most important thing. So that brings me to the dialysis bundle. Right, and we could have symposiums, and I'm sure there have been symposiums on the dialysis bundle. Right, the intent, I'm sure, was good. Right, it was to provide quality care and hold down costs. Whether it's done that or not is a subject that could be debated. How it should be modified, should it be modified? Another subject that should be and could be debated. But we were very concerned that if phosphate-lowering medicines go into the dialysis bundle, then it interjects another decision maker between the patient and their physician, right? Choice of medicines and care should be between a patient and physician. And if phosphate binders are in the bundle, right, that pulls the dialysis provider, right? It pulls the profit loss statement, it pulls their stockholders, it pulls all these things into the middle of that decision-making, which we feel should be between the patient and the physician. And we're working with our partners, both physicians, both patient advocacy groups like yourself, even the dialysis providers. I think we're all sort of aligned that putting phosphate-lowering medicines into the bundle is probably not a good thing. And as many speakers have said before, the group that gets hurt the most by some of these decisions are the patients. So as you know, just very briefly in terms of the access to care history, in 1972, dialysis services were covered by Medicare. In 2011, right, the bundle was developed, and at that time, intravenous medicines that were given on dialysis were included in the bundle, and oral medicines where there was an IV equivalent went in the bundle. And in 2014, the plan was to put phosphate-lowering medicine and other oral medicines into the bundle in 2016. And between 2012 and 2014, Congress debated, and they sort of kicked this down the road to some far in the future date, 2025, where we would all be more civilized and able to make better decisions, right? And here we are now, and it's 2023, and we haven't yet solved this problem. Currently, phosphate-lowering medicines are scheduled to go into the bundle in 2025, and obviously preparations need to be made for that relatively soon if that's going to happen. So right now it's going to take an act of Congress to prevent phosphate-lowering medicines from going into the bundle. And as I said, we're working with both physicians, patients, patient advocacy groups, dialysis providers to try to convince CMS that that's a bad idea, and particularly a bad idea for patients. So let me summarize and conclude with these journeys. I think the scientific journey, like so much science, when it ultimately gets to some answer, is a thing of beauty, and that's what I've tried to show here. The regulatory journal has been a little bit of an uphill battle with some twists and turns, to say the least. We think there's a light at the end of the tunnel now, and we're excited about that. And the access to care journey, I think, is still a big question and still unknown and still a lot of work to be done. We think if we all sort of row together, we'll get to the point we need to be at, which is hopefully to keep these phosphate-lowering medicines and other oral medicines for patients out of the dialysis bundle until we have a more sensible approach to funding care and providing quality care to patients. So let me stop there and thank you for your attention.
Thank you so much, Dr. Spiegel. And we're appreciative of you being here to share the work that you're doing. Thank you again to all of our session speakers. This was a very excellent and robust session.